Thank you. Thank you to Saul and the whole Teledermatology Congress for the invitation. This is going to be a fairly succinct, lean presentation based on the fact that it's the end of the afternoon, end of the Congress, and people may have travel commitments they need to get to. So this is Oxford, which is a beautiful city, not far away, about an hour. If you have an hour this afternoon, there's a train station just next door in Marylebone. You'll be in Oxford and to actually see the Dreaming Spires and cricket, which is now finished. So I've got a few disclosures, as mentioned. This is the challenge we have, and I think actually the group of people here are not the problem. We are hopefully trying to find the solution to try and get technology to actually make medicine evolve in the right way, so that hopefully whatever technology we're embracing and utilising is going to be safe, effective, and going to improve healthcare going forward. So this is where we are here. Now, we do know with any form of healthcare, there'll be any form of innovation, there'll be people who will be hesitant about trying to embrace this. And particularly that's been the story of dermoscopy, which we now know is embraced by 98% of British dermatologists. But that's only 98%. So there's still 2% who are a little bit outlying, and important that they need to change practice. It's no longer acceptable not to use technology in clinical practice that helps make better choices. So what I'm going to talk about really is just two projects I was involved in about trying to work out how to actually make these projects a little bit better going forward, and actually the challenges and the problems that we came across in doing so. So we have this innovation, and what we're going to try and do is adopt teledermoscopy, whether we should be adopting it, but if we do so, how to do it in the right way. And it's complex, isn't it? You can't just give people tools and say, away you go, and you'll do better. It's complex, the process. So there's a complex chain about events from technology at one end, with a patient, through to end result in hospital the other side. There's a lot going on. And that can be problems associated with the patient, the GP, the Teledermoscopy platform, the imaging regarding this, and also the opinion upon which the image is undertaken, and also the hospital facility at the end. So there's a lot of opportunity for problems to occur in order to cross this gap for technology to be adopted. So two pilots we'll talk about. These were undertaken over the last few years, actually, and the most recent one just completed early on this year. So first, this was a planned teledermoscopy pilot in the UK in 2012. And it was driven by the Clinical Commissioning Group, which is the group of GPs and healthcare owners for the population in the UK, which is not secondary care. And they're making the choices about how to actually use their services and which services to buy. And they were looking at their dermatology service and wanted to redesign the pathway. And they thought adding a teledermoscopy element to this pathway may be helpful. But interestingly, the secondary care provider was very hesitant. They were not keen to actually get involved in dermoscopy or teledermoscopy. And that was actually just due to a lack of utilisation of dermoscopy in their clinical practice. This is 2012, so not too long ago. So they put up barriers. They said, no, we can't engage in this. This is not going to be a pilot project that's going to work, unless we go from a teledermoscopy project to actually including inflammatory lesions. So again, the actual pathway was then changed. So disruptive innovation. People didn't want to change, didn't want to actually partake in the pilot, change the actual pilot itself. So we changed the barriers, brought things down, and so actually became a teledermatology pilot, which has already happened beforehand. So pilots can evolve and change, and that's a problem that maybe we should try to avoid going forward with other cases. Patients, all routine cases, were referred from primary care, and the GPs, there was no mandated pathway. So the GPs had the opportunity to actually utilise patients on a pathway or not. It wasn't all the cases. The teledermoscopy imaging was provided by 12 motivated GPs. And these GPs were fantastic. They were wanting to engage in technology, wanted to upskill themselves in diagnosis, and quite frankly, they were fantastic by the end of the actual pathway and the end of the pilot with regards to diagnostic skills, image acquisition, and interpretation. They were located across the catchment population, and they had a dedicated clinic, again. And this is another one of those choices that you have to make. Whether if you're having a service, that's probably a message from New York, than our next speaker. But if you're having a service, you've got to work out how you utilise people's time most efficiently. And obviously, if you have a GP who's normally seeing 20 or 30 patients in a session, now only seeing 10 in a session in a dedicated clinic, that might not be the best utilisation of time. The platform was the telehealth diagnostics platform, which is from Australia, and it was performed via the N3, which is a secure encrypted network. Now, this is where it's quite fun. Again, with any innovation is the people at this far side, trying to get them on board with dermoscopy. So the local hospital had limited experience, but thankfully they embraced this, and they actually employed a consultant who actually had an interest in skin cancer diagnosis. So actually, things evolved during the course of the actual pilot. And the hospital, all the cases were reviewed by the local team. Now, this is important as well. Any innovation, you need to educate not only the providers, but everyone on the pathway needs to be told how to actually use the pathway. And so we had education at the start of the pilot. All the GPs were involved in the training manual with regards to image acquisition, and also 3 monthly, 3-hourly sessions of dermoscopy education. And during that time, we audited the cases that were coming through the service, and they all had equipment provided by the local clinical commissioning group. And here are the outcomes that we had. So we had 2,264 cases in just over a year. And you can see the usual sort of uptake. It's slow, slow, slow. And eventually, the summer months as well, people were taking their clothes off, finding lesions perhaps, turning up to the actual hospital department, the peak in the summer, and then things gradually tailed off, and the pilot finished at the end of the year. And so this was a teledermatology pilot as well. And unfortunately, we can't separate the data with regards to lesions versus inflammatory dermatosis. That wasn't available in the database subsequently. But 2,264. And what we showed was about 24% of cases needed no onward referral. So they were a straight, we did need to see them again. 42% needed to come to hospital, and about 34% would benefit from a plan in primary care and ongoing management back in the community. And interestingly, what you can do is obviously stratify those referrals to hospital who've actually required an urgent appointment versus who required a more routine appointment in secondary care. Pilot B, different project. This was a teledermoscopy project from the outset, and it was again developed by or commissioned from the local commissioning group. They wanted to actually implement this change. It started off as a lesion-only pathway and remained as a lesion-only pathway, which is helpful rather than things twisting and adapting. The GPs, again, they had the opportunity to pre-select patients, so it wasn't mandated. Mentioning this mandated pathway is important with regards to cost and finance, because it will help to determine how many cases go through a system. So GPs had the opportunity to actually choose who would be the right candidates to actually be used on this pathway or not. Again, about 16 GP practices that were used as hubs around the area, also had nurses training imaging as well. And the teledermoscopy opinion was a remote opinion, that was me, and a colleague in London, and we cross-covered with regards to holiday and also for internal audit and validation of cases. And again, it was a telehealth diagnostics platform via the N3 network, but they also had a management provider in health to help you with the infrastructure. And what they did was put in a remote management system. And I think, again, you're now complicating a pathway by adding in extra pathways, and maybe this may not have been so helpful. And the hospital, two find routes of practice, be it primary care or actually 2 hospital end reports. And this was what's determined at this point here, essentially. If we said secondary care, they could choose what was the most appropriate end point based on their local skills. Education. This actually was actually somewhat limited, to be honest. It was at the start of the pilot, but very little ongoing through the actual case of the pilot, which was a shame. Dermatoscopes with cameras were provided by the CCG, and there was an internal audit. So here we can see the numbers. Now, we mentioned, or Leonard spoke eloquently yesterday, about you introduce dermoscopy or introduce education, telemedicine, and initially there's an uptake. But as the GPs get upskilled, and they get better, there's a downturn in actual cases. Now, you could argue that was the case here, apart from when it reached a certain point, after about 50 cases per month ticking over, there was a precipitous drop. And that actually came back because the RMS system here, there just wasn't enough cases that provider thought were going through the system. So it was pulled. So unfortunately, a precipitous drop there wasn't purely the fact that GPs got so good at diagnosis, there was an outside influence that caused the termination of this pilot. 1,229 cases over 26 months. So again, the breakdown, and can you see a difference in the pattern of numbers here? So we have 44% who required no onward referral, and 50% who actually required a referral onwards. And in hospital setting here, 29% were deemed to be an urgent case. So it's a very different demographic mix compared with the teledermatology pilot. So if you compare the two, a teledermatology pilot, 2,000 cases or so, there's a lot of management back towards primary care, ongoing, and that's probably because of all the inflammatory dermatosis. Try this, try that, and feedback. Whereas the teledermoscopy pilot here of 1,200 cases, most of the cases were managed in a straight binary distribution, either no one referral or secondary care. And again, on those secondary care, you can see a higher proportion of those cases will require urgent slots. So if you're going to divide a service, it's perhaps helpful maybe to actually look at, whichever choice you're using, how they actually was going to influence the demand later on and to adapt for that, perhaps. So, in summary, around about 3,500 patients were put through these both pilots, and the experience shows that, in our case, a teledermatology service is more of a management system, because a lot of management will take place in primary care, whereas the teledermoscopy is more of a binary outcome, either no one referral or into secondary care, and at a higher frequency of urgent referrals. We need to address education. So if we're going to introduce any of these pilots or ongoing platforms, it's important to actually make sure that all parties are involved with ongoing support and education. And as mentioned yesterday by David about the importance of cost. So cost is important because there will be some elements of the pathway where cost is their prime provider, prime driving process. And we need to adapt that to incorporate it into a list to work out whether it will be cost effective and based on the numbers that are planned to go through the system. So with regards to crossing that chasm, it's not straightforward. You can't just support everything and think it's going to be straightforward and just walk across and everyone's going to follow you. There's lots of things you need to put in place. The providers, who's going to be providing the service and their expertise. Look at the pathway itself, and a pathway that is very clean and less people involved perhaps has an easier way of actually getting to an end point and being adopted rather than pathways that have an opportunity to become more complex. The cost is very important, and education. So in summary, there's a lot to do to actually get any project across to be adopted, but hopefully addressing some of these issues will help. And if we can't do that, there may be a different pathway. We've also mentioned about the public are becoming more engaged in technology. And if they find their own image, they may be able to hop across. And that might be the future. Crossing the chasm. And if anyone has any time this weekend, David will know this site. Unfortunately, Oxford doesn't have any chasms. But I trained in Bristol undergraduate, and this is the Clifton Suspension Bridge, which is a great destination for the weekend. Thank you.